So welcome to a talk on ischemia. So Ashley, do you want to have a look at this ECG and to comment on what it shows? So I'm going to show a few ECGs while we're waiting to have everybody join that show evidence of ischemia to show the sort of presentations we're expecting.
Sorry, did you say Ashley?
Yeah, is that you're down as being Ashley Brown? Is that not you?
I was just on the phone, so I hung up. Don't worry. So ECG, taking a quick look. So it's sinus rhythm. There's some clear ST elevation in certainly the inferior leads of 2, 3, and AVF. I can't see it anywhere else, but there looks to be some reciprocal changes to go along with that in the anterior leads mainly, 2, 3, 4, sorry, V2, 3, and 4, and a little bit in AVL. So on balance, just from the obvious abnormality, it's a inferior STEMI with reciprocal changes. There's a couple of there's nothing else I can really note on with T wave inversions anywhere else. No obvious Q waves. No obvious QRS morphology changes. So I think it's just a STEMI.
Yeah, absolutely. Very good. That was an excellent description. One thing I would add to your description is, can you see that there are the normal or expected size R waves in 2 and 3? Obviously, we don't know what this ECG looked like yesterday, but the suggestion here is this is an acute STEMI because we haven't lost any R waves. So there aren't any Q waves. There isn't any loss of R wave, and we've got inferior ST elevation with anterior reciprocal changes. And it's really important to see the reciprocal ST depression, because if this were a pericarditis, for example, you wouldn't expect to see this, or if it were an old infarct, you wouldn't expect to see reciprocal changes. So when you're looking for a STEMI, look for ST elevation, but also look for reciprocal changes. And of course, this patient needs to come straight into hospital, or if they're in hospital, you need to put out a STEMI call. No messing around trying to speak to a senior or getting further advice from anywhere. Doesn't matter where you are. If you see a STEMI, you immediately put out a STEMI call, and after that you can start worrying how you look after the patient. But we need a STEMI call so that we can get the cath lab ready for the patient, and you can get all the help that you need coming to you if you're in hospital. If you're out of hospital, then just an ambulance. Great. What about this ECG? Does anybody want to comment on what this shows? So it's another type of presentation with chest pain. And this is deep anterior T-wave inversion extending from V1 all the way through to V6. There isn't any obvious ST elevation, and there aren't any ST depression or reciprocal changes. And this is the sort of T-wave inversion that can often appear 24 hours after the patient has chest pain. So if they've had pain in the last 5 minutes, you will not see this ECG. But if they had pain 24 hours ago and you're not sure if that's ischemic or not, often these ECG changes develop. And this is an LAD syndrome ECG. So this makes you worried that there's a proximal LAD lesion, which is going to mean that a great deal of damage can happen to the heart. So very important ECG to spot. This is suggesting that if we delay intervening and there's further ischemia in that territory, a lot of damage could happen. So very important to, again, look at getting this patient urgent treatment. And another type of presentation. This again is a patient complaining of chest pain. This is a slightly more difficult ECG perhaps? There's another different thing that I'm wanting you to spot on this. Do you want to take a moment to look at this ECG and tell me what you think? So we got T-wave inversion, as we just described, throughout the anterior leads, not quite as far as the lateral V6, but throughout the anterior leads. This time we have got a bit of ST elevation in the anterior leads, but there are no reciprocal changes anywhere else. So this looks like ST elevation, but without reciprocal change, we're not thinking of this as being an acute STEMI. You obviously need to be sure about that because it's a critical diagnosis not to miss. But look carefully at the anterior leads, and you can see that there's a loss of R wave and in fact Q waves in V1 and V2. And this is what a old anterior infarct might look like, and the presence of persisting ST elevation points towards them having an LV aneurysm. And this might have happened a month ago, or it might have happened 20 years ago. We don't know from the ECG the exact date of the episode, but this isn't an acute infarct. So the patient may be presenting with chest pain and this ECG might be unchanged over the course of the last few years. Old ECGs are absolutely critical because you're looking to see if there's been any dynamic change within that. Sometimes inverted T waves can flip upright when a patient is ischemic. So this ECG suggests an old anterior infarct and potential left ventricular aneurysm, and doesn't reflect acute ischemia. And one more ECG. Can anybody tell me what this ECG shows? So I think this is one of the hardest ECGs to diagnose, because I've put this up as being an ECG that's within normal limits, and I tend to like the term within normal limits rather than saying normal, because it just gives you a little bit more wriggle room. Actually saying an ECG is truly normal is quite hard, but this is a normal ECG for the purposes of this talk. And what proportion of patients presenting with acute coronary syndrome would you say have normal ECGs? You can unmute and speak or just type it in the meeting chat. Just a guess, what proportion? 30%, great. Any advance on 30%? So it's a figure that is going to be incredibly dependent upon the population that you choose to study. If you look on a coronary care unit, you might get a very different answer to if you look on the clinical decisions unit or A&E, but studies have suggested 50%. Certainly, the important thing is it's very common to have a normal ECG when you're having acute coronary syndrome. So pathology helps you. But a normal ECG does not, because, for example, the patient with the LAD syndrome ECG probably had a fairly normal ECG on the day of admission, and the LAD syndrome appearance as the deep T-wave inversion only developed over the next 24 hours. If you have any problems with diagnosing ischemic ECGs, I've done a series called Fun with ECGs, and I plan on doing lots of different series with it, but I've started off by doing ischemia. So there are 13 ECGs, you get a minute to have a look at them, and then a couple of minutes me describing what it shows, so you can test yourself and see if you can diagnose ischemia on ECGs. Wonderful. So then on to the sort of the meat of the talk. Obviously, being able to diagnose this, being able to understand the ECGs is very important, but these are the sort of the clinical information to go with that bit and the management. So we're going to talk about the differential diagnosis of chest pain and how do we decide if chest pain sounds cardiac or not. Then we'll talk about what features suggest stable versus unstable angina. We'll go over the acute coronary syndrome side of this, so types of myocardial infarction, and obviously not all troponin releases are myocardial infarction, so we'll go over that. And we'll talk about how we manage different types of acute coronary syndrome and a bit about how we manage stable angina. So hopefully this talk will give you basically all you need to have to manage coronary artery disease. So if we come back to the chest pain differential, can you suggest on the chat or mute yourself and speak? Can you tell me some differential diagnoses? And can you tell me what symptoms might point you towards that differential diagnosis rather than pointing you towards acute coronary syndrome? So what symptoms, if you've just joined us, we've only just started talking through ischemia and acute coronary syndrome and coronary artery disease management. So we're starting off just what's the differential diagnosis that we need to be aware of? I mean, it's a very open question, and let's talk through it because we do have quite a lot to get through in the presentation today. I hope you managed to join last week for the acute coronary syndrome cardiac causes of chest pain. We talked about lots of these things then. It's on the YouTube site if you missed it. But if we then think about the pulmonary causes, there are things like pleuritis and pleurisy with chest infections or pneumonitis. You can have a pneumothorax, which will cause pain. You can have chest tightness due to an exacerbation of asthma or COPD. And obviously pulmonary embolism can cause chest pain, or mesothelioma or lung cancer can cause pain. But the hallmark of respiratory pulmonary causes of pain is they tend to be pleuritic. So you're after sharp stabbing pain, which is worse on inspiration. And pleuritic nature of the pain is a very helpful for ruling of pushing you towards pulmonary cause rather than cardiovascular cause, with the exception of pericarditis, which obviously can have quite similar features and does tend to relate to posture, but also to inspiration or coughing. There are also the GI causes, and so GORD or GERD if you're American and can't spell esophagus. The particular one to be aware of with GI is esophageal spasm, because the esophagus has got smooth muscle in it, and if it's being irritated with gastroesophageal reflux, then it can go into a spasm, which is relieved by GTN spray. So pain that's relieved by GTN spray can point you towards esophageal spasm, and it can be quite an accurate mimic for angina. So be aware of that possibility. There are obviously musculoskeletal causes, the big one being costochondritis, can be really helpful if when you press on the the junctions between the ribs and the sternum, and you find a specific point which is tender, not generalized tenderness, but a specific tender point, and when you press on it, it makes the pain worse. That's what costochondritis is, and then it immediately becomes obvious when the patient realizes it, and it's then worse often with taking deep breaths in or coughing because they're working those joints more. It's very common for chest pain of any cause to be made worse if some doctor comes along to a person feeling pretty poorly and starts prodding and poking them. So you're after the pain being exacerbated when you hit a specific point and it being the same pain made worse. And then there are obviously various miscellaneous causes, and obviously anxiety can be a common cause of chest pain. Chest pain's within the top 10 reasons people go to see their GP. So there are lots and lots of different symptoms that you get associated with the wide differential of causes of chest pain. And there's quite a nice paper which gets older. Every time I look at it, it's 2005, but it was really a good sort of summary of all the different studies of history taking in diagnosing chest pain. And that found some useful things. One was that radiating to the right arm doesn't make it less likely to be cardiac. Actually, it makes it more likely. Or radiating to both shoulders or arms can make it actually more likely, but it's much less common. So don't rule out, say it's non-cardiac because they haven't read the textbook properly, because it's supposed to radiate to the left arm. Actually, radiating to the arm or shoulders, either side or both, is quite specific for cardiac chest pain. So radiation is important, and it can radiate left or right, but more commonly it radiates to the left side. The other important and useful features are is it's associated with diaphoresis, associated with sweating, and associated with nausea or vomiting. These are really useful, and they double the positive likelihood ratio of it being cardiac. So when you see somebody with pain you think is cardiac, ask about radiation, but also ask about these associated symptoms, because they will very commonly be there, whereas with costochondritis you don't expect them to be present. Worse than previous angina or similar to previous MI, those two things are lumped together. I'm not sure that worse than previous angina is enormously helpful, but being similar to the previous ischemic chest pain and somebody with a history of coronary artery disease is certainly a useful feature. You can see that describing the pain as a pressure is only 1.3 positive likelihood ratio, so it is a bit more likely that it's cardiac, but patients don't necessarily describe it as a pressure. One thing that can be quite helpful is if you just watch the patient, often they hold a clenched fist over their sternum, and that is actually quite helpful in indicating that it's cardiac chest pain before you even speak to them. What decreases the likelihood? Well, if it's pleuritic, it's very, very much less likely to be cardiac or less likely to be an acute coronary syndrome. Positional pain, again, that would make you think of more of pericarditis, and that makes it much less likely to be acute coronary syndrome. Sharp pain, in my experience, patients often think any severe pain is sharp. So if you ask them, is it a sharp pain, and they're saying they've got severe pain, they'll immediately say yes. But then if you ask them, is it feel like being stabbed, they'll say, oh, no, it's much more like a heavy pressure. So just beware of asking, is it sharp, and just accepting that. But if it is truly sharp, that again points more towards a respiratory cause. And then we've already talked about reproducible with palpation and the fact that it's the same pain and there's a specific location to it. Patients very often think that pain that's on the left side of their chest is coming from their heart rather than from the center, because they know that their heart's a little bit more on the left side of their chest than it is in the center. Now that is inframammary location, that's what that means, and that actually makes it less likely that it's cardiac. And if somebody's having unstable angina, we would expect it to be worse on exertion, as well as occurring potentially at rest. So we do expect ischemic pain to be worse with exertion, but obviously if they're presenting with an acute STEMI, they're unlikely to have done much exertion on that day. Whereas if somebody comes to see you in clinic complaining that they're having chest pain every day, and you might be seeing them for something completely different, if it turns out that they run 5K a few times a week and have been doing throughout getting this pain, you can be pretty confident that pain isn't angina. So that's our differential, and that's how we separate out our, obviously I'm sure you're aware of Socrates, and that's a great way of remembering all the questions to ask, but that is hopefully a way of processing the information that you get. But it's important to just separate out stable angina from unstable angina. So can you tell me what makes angina stable? So what key questions or key features of the pain make it stable angina as opposed to unstable angina? Great. So stable angina is exertional, very good. Unstable angina tends to occur at rest, typically, yes. Good. Anything else? So the critical other factors are it's got to be chronic and not changing in nature. So stable angina has to be stable. It has to have been present for some time. There's no precise cutoff between stable and unstable angina. When you first develop a symptom of angina, it's by definition unstable because there must have been some change to cause you to now get angina. It's possible you've suddenly become very anemic, or you've put on weight, or you're doing more exercise than usual. But something must have happened with the coronary arteries that the patient is getting angina now that they didn't yesterday, unless there's an obvious other reason that it's suddenly started. So it's got to be chronic, it's got to be not changing in nature, and it should be exertional. Live. Sorry about that. So the other thing about it is it shouldn't be lasting longer than about 15 minutes. If it's lasting longer than 15 minutes, then you would really be questioning, can it be an angina attack? It's likely that it's causing some damage. So if a patient comes to you saying that they've been having severe chest pain for the last 3 hours and they get it on a daily basis and they're very worried about it, it's very unlikely that that's cardiac pain because of the duration of it. So by definition, new onset angina is unstable and at some point, not precisely specified, I'd say somewhere between a month and 3 months, it becomes stable angina. Unstable angina, as we've said, it can occur at rest and it's new and it can last longer than 15 minutes. So when do you make, if you were working in a non-cardiology setting, so you were in a clinic in gastroenterology, or you were working in a general practice, when would you decide that unstable angina needs an emergency referral? So you phone an ambulance for the patient or get them sent straight to hospital. So not really by GTN over 15 minutes. Yeah, those aren't bad suggestions. I would say if they're currently in pain, or if they've had pain in the last 12 hours and they've got an abnormal ECG. So these features. Now, obviously, you've got to look at the full history, and if you think they need to be sent in as an emergency, then go with what you think. But these are useful things. If they haven't had pain in the last 12 hours, they've got a normal ECG if you're capable of doing an ECG, and if they're not currently in pain, then you could think about sending them to the rapid access chest pain clinic. Now, if we think about what happens when we have coronary atheroma progressing, you've got a cross section here through a coronary artery. And can you see that we have the lumen in the middle and we have the wall? And there are lots of different layers to this that I won't go into. But here, can you see this white stuff in here? This is a fatty cholesterol deposits in a plaque. And actually, a lot of plaques develop outside the lumen. So not all coronary artery disease actually leads to narrowing of the coronary artery. It actually means that the wall becomes thicker and full of plaque. And there may be a very thick cap, fibrous cap over this plaque that is not in any danger of rupturing, so that although this is obviously not a nice thing to be happening to the artery, it might not actually be putting the patient at risk of anything happening. Whereas you might have a new area that has a much thinner cap and can rupture. And these can rupture without necessarily causing symptoms. This is an example where, can you see there was a cap over this plaque here, and this ruptured, and this is clot. And then there was long enough for this clot to have an endothelium form over it, and you can see that that must have roughly halved the diameter of the lumen, so that might have caused symptoms of angina, but it won't necessarily have caused occlusion of the artery. So you can get progression with these plaques rupturing without necessarily causing symptoms. But here in this case, the plaque ruptured again, and you got intraluminal thrombus, which was the cause of death in this patient, who was obviously having a post-mortem to establish the cause of death. And so we need to be able to identify this sort of pathology happening so that we can appropriately treat it and prevent progression and prevent bad things happening. There are definitions to tell us if patients having myocardial infarctions. You'll be glad to know that there is now a joint definition, whereas before, for longer than we can care to remember, there have been lots of different competing definitions of what a myocardial infarction is. But what we need to know is the mechanism behind our troponin release. Because if it's, as I've just shown you, a ruptured plaque, then we should be thinking about doing a coronary angiogram and stabilizing that area with a stent. If, on the other hand, there is another mechanism for that troponin release, it needs a different form of management. So I'm going to briefly talk about this. So the definition of a myocardial infarction, according to these unified guidelines, is that the troponin value has to exceed 99% of the upper limit of the upper range limit. And the troponin can go up or it can change. It can go up or down. That's showing that it's a dynamic situation. Obviously, if you catch the patient after their infarct or early in their infarct, it might go up or go down. And that's got to be associated with ischemia, acute ischemia, and acute damage to the heart muscle. And if so, and it's due to a problem with the blood supply, which is due to atherosclerosis or thrombus formation, then it's type 1 MI, which is due to plaque rupture. Whereas if we've got a problem with the blood supply due to a supply imbalance, we get a type 2 myocardial infarction. For example, if we have a tachyarrhythmia and the patient's heart rate becomes very fast, that might mean that the oxygen supply imbalance is such that you get an area of infarction in an area where there's a narrowed coronary artery that wasn't causing a problem at rest. So this is what we're talking about when we say myocardial infarction. It's entirely possible for troponins to go up that are not associated with a myocardial infarction so much as a generalized myocardial injury. So, for example, if you run a marathon, your troponin will go up, but you've not had a myocardial infarction. Or if you have myocarditis, or if you have a severe illness. I'll come to a list in a second. On the other hand, your troponin level might be stable and elevated. I've got patients whose troponins will be about 1,000 every time you check them. And that's occurring because of chronic myocardial injury. And that might be that they have hypertrophic cardiomyopathy or amyloidosis causing cardiac amyloid. There are lots and lots of different conditions that can do this, but that's a prognostic marker and it's not a good thing. But that doesn't tell you that they've had an infarct because it's always at that high level. And there are other things like renal disease that can lead to relatively high troponin levels. So a slightly more full list of non-cardiac troponin release. I mean, there are any number of potential causes, and just basically if a patient is proper poorly, as we used to say when I was training, they will get a troponin release. And that's a marker of how unwell they are. It's a prognostically significant finding. It tells you that they're a poorly patient, but it doesn't tell you that they need to have a coronary angiogram. So there are broad categories. You can have the demand ischemia. So this would be more like a type 2 myocardial infarction, where there's a problem with the blood supply to a specific part of the heart that can be caused by many different things. On the other hand, you could have direct myocardial damage due to trauma, due to chemotherapy or myocarditis, or due to an infiltrative disorder. You can have strain placed on the heart by severe illness or pulmonary embolism or heart failure, very often causes a troponin release. And there are then smaller print causes, things like the chronic renal failure, infection, and intracranial pathologies. So lots and lots of different things, but just basically, if you're poorly, expect the troponin to go up. So just to go over this again, type 1 myocardial infarction. This requires the troponin to increase, and it requires there to be plaque rupture and occlusive or non-occlusive thrombus. So a blood clot needs to form and cause obstruction to some extent of the coronary artery, sufficient to be causing some symptoms and the troponin release. And we need, for it to fall into the type 1 myocardial infarction definition, not only the raised troponin, but we also need symptoms or ischemic ECG, or evidence from imaging of loss of function compatible with ischemic etiology, or coronary angiogram identifying the thrombus. So fairly obvious things, but that's what everybody agrees a type 1 myocardial infarction is. So raised troponin and something to tell you that a coronary artery has blocked due to a thrombus. Now, it's very rare to have a partially occluded artery not cause a troponin release. So if you imagine a blood clot forming here, it might only 50% block the artery and might not be enough to cause symptoms, but bits tend to go further down, and the coronary artery vasculature is a bit like a tree. The further down you go, the greater the absolute cross-sectional area of the vessels, but the smaller they are, and these bits that break off and go down will cause blockages further down, sufficient to cause some sort of troponin release. It really is a very, very sensitive marker indeed these days. So even if you have a non-occlusive thrombus, you are still expected to cause a little bit of downstream effect and either cause angina because of this extent of the narrowing, or little bits of infarct further down. Type 2 myocardial infarction, on the other hand, that, as we've said already, is a supply and demand imbalance in terms of oxygen delivery. And so if you have atherosclerosis, that means that the artery is quite tightly narrowed. There might be enough blood flowing down when you're well, but if you become septic, you might have greater demands on cardiac output, and you might not get enough blood and oxygen to the heart muscle such that you get an infarct in that area, and that would be a type 2 myocardial infarction. Rarely we can have vasospasm sufficient to cause infarct, or you can have microvascular dysfunction. So very thickened hypertensive hearts, you can imagine how difficult it can be to get blood all the way into the most innermost parts of that thickened muscle, because the diastolic pressure is higher. And remember, coronary perfusion happens during diastole. Don't worry too much about coronary dissection. That's a very small print thing. Another rare thing is you can even have oxygen supply imbalance without there being narrowings. So, for example, if you have very severe aortic regurgitation, that can increase the diastolic pressure because all the blood falls back into the left ventricle. So rather than not the diastolic pressure in the arteries, it increases the diastolic pressure inside the heart. So it becomes much harder to get blood around the coronary arteries because of this high diastolic pressure in the heart. And actually your systemic diastolic pressure might be unrecordably low because all the blood's falling back into the heart. So you've got much less head of pressure pushing blood round. So there are rare cases. So these are type 2 myocardial infarctions. It's a problem with the oxygen supply. And you can see immediately from this why it might not help to rush in and put a stent into these. Maybe we should do this, but it's not going to help in the acute situation. Treating the acute sepsis or acute reason that they're unwell should help deal with it. So as I just was saying there, yes, this is a summary slide of that. So bear in mind if a patient with a type 2 myocardial infarction is a high-risk patient, there is a reason that the troponin has gone up. Either they're very sick or this myocardial injury on top of them being very sick is bad news. But the way you need to treat them is to really well manage the cause of their type 2 myocardial infarction, for example, sepsis. And once you've done that, we can treat their coronary artery disease as you would stable angina, and I'll come on to that towards the end. So troponin is our #1 blood test to decide if patients have had an acute coronary syndrome or not. And obviously, as we just said, there are different types of acute coronary syndrome and there are different reasons troponin can go up. But this is our critical blood test. And there are lots of different assays. They are very, very sensitive. They've got a very good non-negative predictive value. How do we actually use them in Glenfield or in Leicester? So this is the troponin pathway that should be on CDU and in A&E, and we'll just talk through it fairly quickly. You're looking at the ECG and the symptoms to think, do they have a fairly typical picture of an acute coronary syndrome? And if you think that their pain is compatible with that, we should be then going on to do our high sensitivity troponin. Now, if the patient has dynamic ECG changes while you're waiting for the troponin results, your troponin test is no longer any good because further things have happened during that time. And the fact that you think that they've got a history of acute coronary syndrome or compatible with it, maybe it's a bit atypical, but it could be it. If they've now had further dynamic ECG changes, then immediately move on and treat them as an NSTEMI while you're waiting for a further result. When you get the result back, if the troponin is less than 5 nanograms per litre and the sample was taken more than 2 hours after the onset of chest pain, then you've ruled out an infarct. If they've presented very rapidly or the most significant episode of pain is within the last 2 hours, then that's not sufficient. So we would need to think again and do another troponin test. If your high sensitive troponin is over 100 nanograms per litre, that's our threshold for saying that this is some sort of infarct. And a troponin of 100 is a tiny, tiny, tiny bit of infarction. Interestingly, actually, the level of troponin doesn't have an enormous impact on prognosis so much as just it being positive is very prognostically significant. So as soon as it goes above 100, we call it a myocardial infarction, even though just over 100 is a very different beast from a troponin of over 50,000. Now, if we have got our troponin within 2 hours and it's negative, less than 5, we then do another troponin. Of course, if you have further ECG changes while you're waiting for that troponin, then act on them straight away as you would have done first time round. But when you've got that second sample, you're looking again to see is it over 100, in which case that would be diagnostic of your acute coronary syndrome, but you're also looking to see has the value changed. So if the value started out at say 6 and it's now 9, that's enough. It's a very sensitive marker. That's enough to say we need an explanation for that. Now, that doesn't mean that they've necessarily had a coronary artery lesion or an infarct, but maybe they're just septic and unwell. But that does need to think about and explain why that troponin has changed. So we're ideally looking for it to go over 100. But even a very small change in the troponin value does need further consideration. So that's how we use troponin and symptoms to decide what type of myocardial infarction we're dealing with, and do we start treatment as per an NSTEMI. Please ask any questions as we go along, and I'll move on now and just cover the management of an NSTEMI. So assuming that we've got a history that's suggestive of NSTEMI and we've got dynamic ECG changes, we would move straight into treating our NSTEMI, as we just said. If we don't have dynamic ECG changes, then we might want our troponin back first, because we don't want to treat patients who are not having ischemia with medications that could make them bleed. And so once we've confirmed our NSTEMI and our type 1 NSTEMI, so our ruptured plaque coronary artery disease NSTEMI as we believe it to be, we want to treat the patient with aspirin, 300 milligrams loading, then 75 milligrams once a day. We used to use clopidogrel, but it's been shown that ticagrelor is superior to it, so we tend to use ticagrelor now, 180 milligrams loading and then 90 milligrams twice a day. We want to give Clexane, 1 milligram per kilogram twice a day for 48 hours, and start atorvastatin 80 milligrams once daily. Bear in mind that a young patient, we should definitely do this, but if you've got somebody who's an asthenic, frail, elderly patient, then big dose of atorvastatin can increase risk of rhabdomyolysis or liver damage. So going in with 40 might be a much more appropriate dose. So while we aim to give 80, and that should be the sort of presumed dose, if you've got a frail patient, please do think about that. And we can also be looking at giving the patient bisoprolol and ramipril, depending upon what their blood pressure and heart rate are like. Please check their lipid profile. If it's been done recently, then it doesn't need to be repeated. Similarly for HbA1c and thyroid function, recent values within the last few months, certainly it doesn't need to be repeated. I'd certainly, 6 months would be fine for thyroid function, but we very important if they've not been done that we do these things. And any patient presenting with an NSTEMI, unless they've got specific reasons that we would be worried about proceeding, we should be thinking about doing a coronary angiogram query proceed. So what might make me think twice? If we've got somebody who's very frail, it might make me question whether or not it would be likely to be helpful, because often they have got quite complex high-risk coronary artery disease, and it may be better to try and stabilize them medically first. If a patient has got bleeding problems, we have to give anticoagulants, antiplatelets when we put stents in, so that might be a reason not to proceed. There are obviously going to be many potential other things that we would need to think about, but we would tend to go for a coronary angiogram, and the way that's written in the notes is C/C plus or minus. So that's the abbreviation that you will often see in the notes of these patients. They need to be consented, and that's obviously not by yourselves, it's by one of the registrars or consultants, and then they need to be listed for the procedure on the computer, and I hope you've all been shown how to do that. The other side of management, and very, very important, is lifestyle measures: smoking cessation, healthy eating, regular exercise, and cardiac rehabilitation are fantastic at organizing all of that. So that's management of NSTEMI. Any questions so far? So moving on to management of STEMI, we talked about this in the first presentation, so I don't want to go over all of that too much, but we need to put out a STEMI alert, as I said earlier, and you do that by dialing 4-2s just as you would for a crash call. It's an absolute emergency that you get help as quickly as you can, because minutes mean myocardium. The heart is dying. You can reduce the damage by getting them into the lab and having their procedure as soon as possible. So once you see an ST elevation and myocardial infarction, don't hesitate. If you are satisfied with the diagnosis, put out a STEMI alert. We would much rather a false positive than miss something. We give them aspirin as before, but instead of ticagrelor, we use prasugrel. So prasugrel has been shown to be slightly superior in this situation. So we give this 60 milligram loading, 10 milligrams once a day thereafter, unless they are any of these, so over 75, under 60 kilos, or they've had a previous stroke or TIA, in which case we would use ticagrelor. I hope that all makes sense. Then there are special situations. So the ones that I want to talk about are anticoagulation. So anticoagulation is more and more common these days because so many of our patients have atrial fibrillation, but of course they could be on anticoagulants because of previous pulmonary embolism, for example. These patients do need an element of individualized treatment. So this is not catch-all for all patients. And if they've got metallic valves, these are particularly challenging patients. So if you have a patient with a metallic valve who needs a coronary angiogram, that really needs to be discussed with the operator who's going to do the procedure. Often the operators will continue warfarin. And if we go through the radial artery, that's fine. If we're having to go femorally because they're radial artery spasms, then the risks of bleeding go up. So that's why we sometimes want to stop the warfarin. So need to discuss with the operator, but probably we would continue warfarin if they're taking it. If, on the other hand, they're on a DOAC, which we would encourage patients with atrial fibrillation to be on, but of course metallic valves need warfarin, for example. So if they're on a DOAC, then unless there's a very, very good reason, like an acute pulmonary embolism, that they don't pause the DOAC, then that should be held off 48 hours before the cath. So if they're on, for example, rivaroxaban, which is once a day, they wouldn't take it on the day of the procedure or the day before the procedure, and that would be sufficient. And the operator will then advise on post-procedural treatment. So again, if they've got a very, very strong reason to be on the DOAG, say they've had a previous stroke and they've got atrial fibrillation, they've got a very high chance VAS score, then speak to the interventionist and see what they want you to do. Post-procedure, often we give 1 month of aspirin, clopidogrel, and DOAG. So triple therapy, we call that. And then from 2 months to 12 months, we give dual therapy, clopidogrel and DOAG. And then after 12 months, there's been shown in the FIRE trial that there isn't any benefit to taking an antiplatelet and DOAG. That just increases risks of bleeding. So we just give a DOAG after 12 months. But this will be specified by the operator. This isn't something you should have to remember. It should be specified. Another special case is diabetes. So make sure that you measure BM in all patients, and HbA1c really should be done in all patients just to make sure we're not missing something. If the blood sugar is very high in the acute setting, so over 11, then we should be starting a sliding scale insulin. We don't want excessively tight control. We're not trying to get the blood sugar down to 4. Down to about 7 or 8 is probably about right. But we do need to control it a bit. And the diagame studies, which are quite historic now, indicated that. The diagame studies are slightly confusing because initially they seem to suggest patients should then be managed with insulin, but actually probably what they just need is good control of their diabetes. And the diabetes team liaise closely with us, and we do very much ask for their help in determining the right diabetes treatments post-infarct, and that basically means good control of their blood sugars. What does coronary angiography involve? So I've already talked about if we go through the wrist, the risks of bleeding are lower than if we go through the leg, because you can easily press on the wrist if it bleeds here and tamponade the bleeding. Whereas if it's a femoral approach, it's easier to do it from a procedural point of view. But if you have bleeding, it can go retroperitoneally, and that can be life-threatening. So we tend to go radially by preference, but particularly small patients or some patients, their artery spasms, and that can mean that it's very hard to push the catheter up and very painful. So we have to switch and go femorally. And we use different shapes of catheter in order to get our tube that we start here by twisting and turning and advancing and retracting. These secondary and tertiary and primary bends allow us to twist around in the root of the aorta and push the tip towards the coronary ostia. So it requires quite a lot of manipulation sometimes to get it into the right spot, but we then, once it's in there, can take some pictures. And this is an example of a left coronary artery. So here we have the left main stem, the left anterior descending artery, the circumflex artery, and then the branches of the circumflex are called obtuse marginals. Branches of the left anterior descending artery are called diagonals. And over here we have the right coronary artery. And if you look at the narrowing here, can you see this is normal here, this is abnormal here, it then goes back to normal over here. If we're putting a stent in, we need to land it in healthy areas. So we need to stent across this area. If we just stented to here, we'd end up with a step down at the end of our stent, and that would be at high risk of clotting and stent thrombosis. So we need to stent across into healthy tissue. And this lesion is a bit like an apple core in this view. If you imagine that you eat an apple core equally from each side, it looks to be nibbled out from all angles. There also, plaques can be what we call eccentric. So can you see here? This area is almost the same diameter as the bit before and after it, but is much hazier. And that's an eccentric plaque. Remember, this is a 2D image. So imagine this whole thing filled with contrast and you're taking a picture through in this direction. Your picture contains the accumulated depth of contrast here. And so it's dark. But if you halve that depth of contrast, it becomes much fainter, as it is here. So plaques can be like this apple core, but very often they're more eccentric than that. And we have to look at the heart from different angles in order to actually see which arteries are narrowed or not. And this narrowing might look like this in another view. So we've talked a lot about coronary artery disease and acute coronary syndromes, and we've talked about how to manage type 1 and type 2 myocardial infarctions. But what about stable coronary artery disease? So how do we manage stable coronary artery disease? Can anybody tell me the answer to that? So we need to address both prognostic treatments and symptomatic treatments. And it really comes down to medications. We can unblock arteries. So it's entirely possible in the acute situation to stabilize lesions with a stent. You can do that in the stable situation as well, and that can make a huge difference to symptoms. So it can be very valuable, but we know that it doesn't improve prognosis. So if you have somebody with stable coronary artery disease and they are symptomatically well, there is no need for them to have coronary angiography. with the exception of patients with left main stem disease, which still does need to have intervention. But other than that, the ischemia trial of 5,200 odd patients, with 80% of them having multivessel disease, so narrowings in more than one major coronary artery, providing they got excellent secondary prevention. And this trial was very expensive, cost $100 million to run. And it's actually, there are others, there's Barry 2D and Courage show the same thing. And they show that there is no prognostic benefit to having an invasive versus a conservative strategy. So these patients don't necessarily need to have intervention. That's totally different for patients who are having STEMI. We know that the combined endpoint of death, reinfarction, and stroke is almost halved by doing a primary PCI compared to giving, for example, thrombolysis. So far, far better that we intervene in the emergency situation for a STEMI. But if we look at stable coronary artery disease, we don't see any of that benefit. There's a slight trend to an early risk from invasive strategy because there is a risk of causing coronary artery dissection and infarct when we do a coronary angiogram, and possibly a slightly lower risk as time went on. And no doubt we'll see 10-year follow-up to this study at some point, but there is no benefit if we look at this over 5 years. So how do we treat? As I said, we look at prognostic treatments and we look at symptomatic treatments. And prognostic treatments are very much the same things that we would use for our acute coronary syndromes. So our statins, aspirin, controlling the blood pressure, lifestyle. It's all very much the same things. And these are really, really important, whether we unblock the arteries or not. Be aware of a trial called the Samson trial. I think this is a fantastic trial that everybody should know about. Only 60 patients involved. Over the course of a year, they spent 4 months on atorvastatin, 4 months on a placebo, and 4 months on no tablets. They had little by way of symptoms when they weren't taking anything. They had the same amount of side effects from placebo as they did from statin. And they then persuaded 50% of the patients who discontinued their statin to restart it when they took their results to them and said, look, those terrible symptoms you're complaining about, you were taking a sugar pill. So try and encourage patients to take statins. They have a very bad press, which is not really fair. And we then can use lots of medications to treat angina. And this is a stepwise pathway that you can use. So beta blockers are first line, or calcium channel blocker like diltiazem will be first line. As a second step, you could add in a calcium channel blocker like amlodipine, for example, unless they still had a high heart rate, in which case you could add diltiazem and beta blocker together. And you could even then add in ivabradine, although it would be unusual for the heart rate still to be high at that point, and I would be starting to get a bit worried. If they've got a slow heart rate, you could go in with amlodipine. You could use long-acting nitrates. And those really are your first line treatments. Low blood pressure, we might be thinking about something like ranolazine or ivabradine earlier on because they don't affect blood pressure. And those are things that we can add as a fourth step as well. So these are good drugs, ranolazine and nicorandil I don't like so much. I don't find particularly helpful. And I have to admit I've never tried trimetazidine. I've never really needed to. But loads of good options. So that summarizes management of coronary artery disease. Thank you very much for listening. I think some key points are to differentiate stable and unstable angina. And we talked last week about how we can differentiate in the clinic with the patient who complains of cardiac chest pain, who's got a history of cardiac problems, how you work out what you need to do something about urgently and what you don't. But that's obviously very important. Bear in mind, troponin's a great rule out, but it is not a very good rule in test. And ECGs are normal in 50% of patients who have acute coronary syndrome, so don't get a false sense of reassurance from it. And if they've got coronary artery disease, there are some fantastic prognostic treatments that we need to get all patients on, and that's really, really important. And if you're not working in cardiology and you think you've got a patient who needs to be seen urgently, the Rapid Access Chest Pain Clinic is a great way of doing that. Thank you very much for listening.